So in the first two sections, we talked about what is tracheostomy, and then we talked about the emergency tracheostomy and elective tracheostomy, and what are the indications for elective tracheostomy. In the third section of our lecture now, we will talk about the permanent tracheostomy, high, mid, and low permanent tracheostomy. What is the technique and steps of performing tracheostomy? And also we will discuss about the tracheostomy in infants and children. So permanent tracheostomy required. Why we need permanent tracheostomy? It's required for cases of bilateral abductor paralysis. If there is bilateral abductor paralysis, we need permanent tracheostomy in the patient. Also, if there is laryngeal stenosis, narrowing of the larynx, we need permanent tracheostomy. Also, in laryngectomy or laryngopharyngectomy, lower tracheal stump brought to surface, and stage 2 skin. So these are all, we need the permanent tracheostomy in conditions in which there is bilateral paralysis, or if there is stenosis of the larynx, we need permanent tracheostomy to be performed. And in laryngectomy is removal of the larynx, or laryngopharyngectomy, when there is removal of larynx or pharynx. What we do is lower tracheal stump is brought to the surface and staged to the skin, and that is also permanent procedure or permanent technique. So all these are the indications where permanent tracheostomy is performed. Now, as I mentioned in the beginning, that it might be high, mid, or low level of tracheostomy. So let's go over what are the positions at which these openings are created and tracheostomy is performed. So high tracheostomy is performed above the level of thyroid isthmus. This is the thyroid. This is the isthmus, and then it is performed above the level of thyroid isthmus. So this is the site where the high tracheostomy is performed. It violates first ring of trachea. So first ring of the trachea is high tracheostomy, and that's where this is performed, above the thyroid isthmus. Can cause perichondritis of cricoid cartilage. Here you can see this is the cricoid, and it's very close to that area. So any procedure performed in that area, it can cause inflammation of the cartilage, or inflammation or infection surrounding the cartilage. Perichondritis of the cricoid cartilage. Can cause subglottic stenosis, is always avoided. So pretty much high tracheostomy is not commonly used procedure. It should be avoided. It is, if performed, it is in the upper level, first tracheal ring above the thyroid isthmus, can cause the stenosis, subglottic stenosis, can cause perichondritis of the cricoid cartilage. Only indicated if there is carcinoma of the larynx present. In such cases, we need total laryngectomy or removal of the larynx. Fresh tracheostome made in clean area lower down. So all these are the indications why we need high tracheostomy. Should not be very commonly used, is only performed when there is carcinoma of the larynx, perform above the isthmus, and can cause perichondritis of cricoid cartilage. Next, mid-tracheostomy, most commonly performed procedure. Mid-tracheostomy is the preferred technique or preferred site, done through second or third tracheal ring, would entail division of thyroid isthmus or retraction upward or downward. So thyroid isthmus may be divided or it just retracted up or down to give space, and second or third tracheal ring is used in the mid level, and it's the preferred method or preferred technique to expose this part of the trachea. So mid-tracheostomy is the preferred technique. It involves second and third tracheal ring, and we can divide the isthmus or can be moved up or down to give the space or to give the visual of the trachea or to access the trachea. Now the third is the low tracheostomy. Low tracheostomy is done below the level of isthmus. So first high above the level, then in the middle, and then this is below the level of the isthmus. Trachea is deep at this level. So here the trachea is located deep, so we need to go deep to access this site, close to several large vessels. So again, this is not a very preferred site because we can damage the large vessels if we go at this site, because the trachea is deep at this site. So as I mentioned, unless it's really very important as a result of some indications, the preferred site to go is the mid site, mid level. Difficulties with tracheostomy tube, and it can impinge on suprasternal notch. So now we talked about the high level, mid-level and low-level tracheostomies. What are the complications associated with them, and what are the most common sites? Next, the technique which can be done. Whenever possible, endotracheal tube is done or intubation is done while performing tracheostomy. Unless we said if it's an emergency procedure, if we do not have time to perform intubation, we should not do it. But otherwise, whenever possible, intubation needs to be done before tracheostomy, and it's important especially in infants and children. Position in which the patient should be, it's in the supine. Supine position is patient lying on the bed with facing upward anterior. So supine patient is on the bed straight on the back with face upward. So patient is in the supine position with pillow under the shoulders to make the trachea push forward. That's the purpose of putting the pillows under the shoulders. Neck is extended. This is flexion, bending. Extension is bending, putting backward, so head is extended. this brings the trachea forward. So it's important that it is bringing the trachea forward. So pillows under the shoulder, neck is extended, patient is supine. That's the patient position in which patient should be while performing tracheostomy. Now anesthesia, no anesthesia if patient is unconscious, we don't need anesthesia. There are no, patient cannot feel anything, patient is unconscious already. No anesthesia if it's an emergency. In conscious patient, what type of anesthesia? 1 to 2% lidocaine with epinephrine is used. Infiltrated in incision line and dissection area. So anesthesia is not given in emergency or if the patient is unconscious, but if it is used, we can use 1 to 2% lidocaine with epinephrine given in the incision line or dissection area. At times, general anesthesia can be given. Now, steps of operation. First, vertical incision in midline of neck, extending from cricoid cartilage to above the sternal notch. This is the sternal notch here. So it extends vertical line from the cricoid cartilage to above the sternal notch. Gives rapid access with minimum of bleeding and tissue dissection. Transverse incision, first vertical, then transverse incision 5 centimeter long above the sternal notch in elective procedures, not in emergency. After incision, tissues are dissected in midline. Dilated veins are either displaced or ligated. Strap muscles separated in midline and retracted laterally. Then we have thyroid isthmus is displaced upward and downward, or it's divided. Few drops of 4% lidocaine are injected into trachea, which suppress the cough. And then we have trachea fixed with hook and open with vertical incision in third and fourth or third and second ring. So all these are the steps of procedure. First the vertical incision, then the transverse incision. Tissues and muscles are separated and then ligated, vessels are ligated, and then trachea is exposed in the fourth or third ring and third and second ring. Tracheostomy tube is inserted in the hole and then it is fixed with the or secured by the tapes. Skin incision not sutured or packed tightly may lead to development of subcutaneous emphysema. So the skin lesion is not closed tightly, can cause subcutaneous emphysema. Gauze dressing between skin and flange of tube around stoma. So it's not tightly inside, sutured because it can cause subcutaneous emphysema. Just loose dressing is placed between the stoma and the tube flange or ends. Indication of tracheostomy in children. Infants below 1 year, why we need to perform tracheostomy? If there is subglottic hemangioma, subglottic stenosis, laryngeal cyst, glottic web, and bilateral vocal cord paralysis. In children older than 1 year, acute bronchitis, laryngotracheobronchitis, epiglottitis, diphtheria, laryngeal edema, external laryngeal trauma, prolonged intubation, and juvenile laryngeal papillomatosis. All these are indications for performing tracheostomy in infants and children. Endotracheal tube or bronchoscope inserted before procedure. So in children, we perform always endotracheal tube or bronchoscope is inserted before the tracheostomy is performed in children. Done under general anesthesia, not local. Do not extend neck too much in children. Before incision, silk suture placed on either side of midline. Not insert knife too deep, injure posterior tracheal wall. So it's in children, we do not extend the neck in the children too much. Trachea is smaller, not very fully grown. There is chance of injuring the posterior tracheal wall. So do not go deep too much, insert the knife too deep because of chances of damaging the posterior tracheal wall. And neck is not extended too much. Trachea incised without excising circular piece of tracheal wall. Some other considerations in infants and children when we perform tracheostomy. We have avoid infolding of anterior wall when inserting the tracheal tube. Selection of tracheostomy tube is important according to the size. Long tube impinges on the carina or right bronchus. Use soft, silastic or Portix tube. Metallic tubes cause trauma. Take post-operative x-ray of the neck and chest. Very important considerations in infants and children. Make sure do not use metal tube, can cause damage. Do not use long tubes, can cause damage to the bronchi. And use soft tubes, and always perform x-rays afterward to look for the of the chest and neck to look for the position or any injury or trauma. So that was all about this section. Thank you for watching sqadia.com.